The first speaker that we were going to have was Dr. Melville, and he was going to talk to us today about maxillofacial bone and nerve regeneration. Dr. Melville is a oral and maxillofacial surgeon, currently located in Houston. He's a associate professor at the University of Texas Health Science Center, and is a well-known and well-respected surgeon for head and neck oncology, microvascular reconstruction, and is currently president of the Oral and Maxillofacial section of the AADOCR. He's a leader in our field, and having worked with him and heard him talk, it's always a pleasure to be able to learn from him. So I'm going to turn it over to you, and we are all awaiting the words of wisdom.
All right. Thank you very much, Dr. Wax. I'm going to put my timer on. Well, thank you very much for the nice introduction, Dr. Wax. It was a pleasure. Last time I saw you in person was San Diego, so it's been a while. But really, from a standpoint, we can go through this really quick. But really, why reason we're here is essentially because of tissue engineering or regenerative medicine. I think this presentation goes aligns with AK. We're kind of trained in the same place at the University of Miami with Bob Marks, which dabbled in tissue engineering, mainly for bone, but other stuff. But really, from a sense, we're trying to complete the tissue engineering triangle with the signal, cells, and matrix. And the reality is it's very simple in the fact that we use BMP as a signal, we use allogeneic bone, and we use stem cells from the hip, which orthopedic and spinal surgery has been using for a long time. So really, proof of concept, tissue engineering, you would always show pictures.
Studies,
but the reality is
60% of the
people
time
think it's magic, but there is, this is my favorite quote from Anchorman, that 60% of the time it works every time, right? So we want to put in a generation that this stuff is valid and works. So once again, in vivo concentration of allogeneic bone, stem cells from the hip, concentrated, and then BMP, which is our signal. And it is simple. I'm just going to run through it because this is a long lecture, but for time's sake, I'm going to flow through it. BMP essentially does a lot more than just bone. We know that for a fact. A lot of research, this was in Nature, saying that if you knock out certain genes for BMP, they have developmental issues. So it can be musculoskeletal, urinary, adipose, and that's what we're using, I guess, from a standpoint of regenerative properties. The other concept is bone marrow aspirate concentrate. So this is from Vascular Journal and New England Society for Vascular Surgery, is that bone marrow aspirate actually does a lot more than just make bone. It actually increases vascularity into the bone. So you have upregulation of BMP, which upregulates VEGF, EGF, as well as bone marrow aspirate, which also is mesenchymal cells or stem cell in general wants to form bone, but it helps propagate vascularity. So you can go from, let me lower this down. You can go from a resection like this, and you can entirely reconstruct the mandible and with longevity. And the beauty of, I think, tissue engineered bone, obviously no donor site, and also there is no minimal loss of bone reabsorption with the autogenous graft versus an autogenous graft. So really, from a comparison for head and neck, we use the paper by Tony Porgirl saying anytime a reconstruction is 6 centimeters or more or midline, that you want to use a vascular flap. And I have no issue with that. I think the reality is I have issue with avascular bone grafts. I don't think they're needed anymore. So reality, a quick case, 65-year-old recurrent OKCs. She's had 9 ENC procedures for OKC. Well, with modern nerve grafting, which I'll go into a little more detail, and bone tissue engineering, I don't hesitate to resect them or go nuclear. So resection, long as I have soft tissue, and you can see the soft tissue with the VEGF from the epithelial growth factor, from the BMP and the bone marrow aspirate, they look relatively low. This is about a 8-month follow-up Panorex showing I don't have residual reabsorption of bone you see with typical autogenous bone grafts. You typically see about 30%. With this, the tissue engineering technique with the BMP, bone marrow aspirate, the allogeneic bone, really low reabsorption. She also got a nerve graft. So we, for our dentist purposes and restorative components, we level out the bone, put implants. Here's our aesthetics. And this is her 1.5 years with no autogenous bone. This is purely only from her stem cells, BMP, and allogeneic bone, fully functional. And I like to show these videos because you can see the progression of the particulate, and with the muscle attachments, The Moss dynamic theory is the soft tissue defines where that bone goes. And you can see the neoforamen on that right side. So this is our complete restoration and no need. And I can go with some neurosensory. This is about a year and a half. She's got full neurosensory directional and 2-point discrimination at this point, about a year and a half. And I wanted to show the direction. So can we do with reconstructing the jaw, right? The midline or 6 centimeter more. Well, if you have vessel depleted necks, this was a case with a pec flap, resection or really vessel depleted, hard to get anything. So pec flap, let it heal, go back secondarily or tissue engineer bone. And then we're able to regenerate a full mandible, long as a soft tissue. And interesting enough, the soft tissue dictates where the bone goes. So you can see the pursing of that lip, and that bone followed the natural lip function of that person. So we were able to put implants, take out the plate just because of the soft tissue or end, and let him heal, and he's got implants there. So really from a standpoint, a patient comes from me from the Netherlands, BMP is not allowed there, but they were offering a myxoma with a scapula resector, and just becomes a cookbook technique. And you can see over time, this is no autogenous bone, segmental defect about 10 centimeters, but this is about a year out. And you can see the oblique ridge regenerate as well as the mental foramen with the nerve graft. So as we mature, this is 2 years out, all those little particulate slides completely fused. And she looks like she has a normal mandible. All we need to do is take out the plate and the mesh. So reality now, we got the implants and they follow me up. And really from a standpoint, like what can this do for us is that this is a doctor from Orange County. She had a giant cell tumor refractory to medical treatment. She didn't want a fibula. She went to UCI and they offered a fibula. She went to tissue engineering with the nerve. And then the one thing she wanted was, I wanted to go get married and take photos. And I was like, you know what, why don't we do the photos in marriage? This is a slow growing tumor, but she was completely type A, thinking about the tumor. So she wanted the resection done. So this is her 5 weeks post-op. And she has a full picture. She sends me the pictures post-surgery, 5 weeks after a jaw resection and reconstruction. So you can see some of the swelling, but she has her dream wedding, gets her implants. And I actually got that picture, Panorex from her yesterday. So this is full recovery, year and 3 months out with dent teeth. So the jaw nowadays, all the new fad. So reality is this is Faye Williams, who's kind of pioneered the corner or is popularized. So he has a patient where wanted to do a fibula, but the fibula is too damn small. So he reached out to me, said, can you look at tissue engineering? And she's had failed autogenous grafts, wondering if you could do anything for her. So this is her Panorex, failed grafts, IV antibiotics. We put in same incision. We put the tissue engineering bone, no autogenous bone, but mesenchymal cells. And then reality is tissue engineering grafts with donor sites, traditional autogenous bone. That's my view. What's the bone maintenance? I've been here 12 years. I can tell you the bone maintenance is a lot better than autogenous avascular bone grafts. And really, there's no shrinkage. And really, I'll talk about that in, I guess, recording when we have the discussion. So from a residence for benign tumors, we haven't got into malignancies, obviously, the growth factors and BMPs. You don't want to be using this for malignant tumor or for benign tumors. I think this is standpoint from a resident's viewpoint. And then looking at avascular blueprints, I've been looking into a study using pentoxifylline. We know it's good for hemorrhage. It's debatable, hemorrhage and ORN, but really from a standpoint, our avascular bone grafts have the same thickness. So I've been putting a lot of patients on pentoxifylline just to dilate the blood, increase blood vessels to those reasons. We know as long as there's blood, we're going to have some new regeneration. So this is a perfect example. Benign tumor, all tissue engineering, allogeneic nerve, bone graft. We create the bone, we create the sensation. This is 8 months out. She's got full sensation. I have her eyes closed. I want to put the implants in. We get the implants in with good bone, full implant. And then this is her sensory. And she's got full directional, teeth, soft tissue, and direct. So the full gamut where you have bone, soft tissue, teeth, and sensory. So that is our goal. So the last thing I want to talk about is sensory reinnervation with allogeneic grafts. So we know from a study it works for benign patients, but how about malignant? So Pat Garvey, a friend of mine at MD Anderson, did a nice study regarding regenerative. But this is a perfect example of one of my patients. Resection, we have, it's a floor of the mouth involving the tongue, glossectomy, mandibulectomy. The good thing, I guess, if you can look at a half glass, half full picture, is the mental nerves are protected. So we do bilateral nerves, we do a typical fibula. And then this is him, he gets IMRT, and you can see he gets cooked. And this is him about, I think, 9 months. I have his eyes closed, he's still cannulated, so he signals when he feels. So the one thing I do want you to take a look at on the side that he does not feel, he does not tell me. So he's not telling me that he's feeling stuff. So the most important part is that when we go to the lip, he is feeling for sure. This is him after he gets decannulated. He has a long decannulation. We decannulate him. He's got directional at this point. And he's officially 5 years out, so he's cured. And his quality of life is awesome, good as can be, I guess, without glossectomy, but he's able to talk, his vocal cords are not affected.
Okay.
So we'll skip into them. He's got his directional. I know my time's running out. Other aspect is I have a patient osteosarcoma, remove the sarcoma, but the casualty is the lingual nerve. So I lose her to follow up. This is our post, pre. And then from a standpoint, she's got sensation of her tongue just by putting in that graft during the surgery, waiting for frozen. So she doesn't bite her tongue whatsoever. And that took us 15 minutes to do. 91, age is always a factor in regeneration. How about a 91-year-old female?
Yeah.
And she's definitely got feeling. You can see that flap there.
Oh, I can feel that.
So not to bore you. And I think I end off with someone who I call it the Usain Bolt of head and neck, I guess, in the world of head and neck. So this is John Nemeth. He's actually a 4-time Grammy Blues winner of the year. And he has the worst type of mieloblastoma where he can be located for a singer. So this is his skill set. And he also does this. So I still remember working through the cancer wards, and the people who had an anterior mandibulectomy would be drooling, speech issues, eating. So he has the worst possible case where the mieloblastoma is, right through the anterior bilateral mandibles. We resect them 4 months. He wants to go to Romania to do a set in Romania. I told him, okay, bone probably looks good. This is a 1.5 years out with full restoration, with all regenerative medicine, essentially. The only thing we took from was stem cell. We get a nice shout out. He wins that album wins his 44th annual Blues Awards winner. And then he's on tour right now. So this is him about a 4 year out after reconstruction. All right. So really, from a standpoint, I think the ultimate winners in our modern technology is the patients and the surgeons, right? We had the armamentarium to make the patients whole. So I will field question. That was a fast run through because there's a lot of slides in there, but thank you very much.
Mute myself. That was great. Thank you so much. I remember your talks from when we were in San Diego, and this is just the tip of the iceberg. And you're really doing some earth-shattering and cutting-edge type surgery. Does anyone have a question? I will always have a question, but I'll let others get something in. If not, I'll ask away. So, nerve reconstruction, I'm willing to bet that all of us are going to say that nerve reconstruction should be a general component of what we do in all of our patients. And I think we're seeing it. And you demonstrated, I think, what all of us would go, yeah, we can do that. We can get that. 10 to 15 minutes for a nerve graft. If you come and spend a year with me, we could probably cut that down to, like 8 or 9 minutes if you really want. But in my practice, nerve reconstruction is a secondary procedure because my partners, they buzz through the mental nerve coming across the mandible with the bovie at 85. And so my ability to reconstruct the nerve, and I'm just being honest here, is it's not nearly as good as it should be. And I'm not sure how to fix that. And so I say this in honesty so that at least, my compatriots on the left and lower down can say, you know, what is it that you guys are doing? And if you've conquered that, how did you do it? Because we really should be doing, you know, what James has said on everybody.
I think from a standpoint, Dr. Wax, it really, at the end of the day, it's economics, right? So patients are now shopping around. So essentially, they will come, they hear from other patients or just other like networks that they have the ability to preserve some of their sensation. Obviously, we don't guarantee it all. And any patients that have a large tumor, I'll tell them really it's a long shot, but you can try. We might not have the margins, but I'm not going to put in if it violates oncological principles. From a standpoint, I think at Texas Medical Center, I think all our Baylor, UT, even MD Anderson has incorporated some type of nerve reconstruction because patients do shop around, especially ones with good insurance. So it becomes an economic issue at some point. And I think that's what the breast surgeons have learned is that they needed to incorporate nerve sensation to the breast because they will go to the doctor that offers them.
Well, I also think that in the 70s and 80s, it was really just about surviving disease. In the 90s and early 2000s, it was about, you know, getting good cosmetic and even a little functional. Now people have very, very high expectations. They want sensation. They want to be normal. And just to be alive and well isn't quite enough. And so that's what you offer them, which is truly remarkable. It's a great part of what we do. And it should be, I would argue, kind of the standard of care, which means that, you know, the ablative guys who are ripping through these nerves need to be on board and need to say, hey, this is important to all of us. So we should, you know, we're going to take the time to find that nerve for you.
Absolutely. 100% agree with you, Dr. Z.
So is this a competitive something in, you know, you're in New York City, so is this something that is competition has driven you to? And the same with you, Joe. You know, you got Penn right across the street and Temple, you know, 6 blocks away. And Arshad, is it because you're competing that now this is because, I mean, it's the right thing to do, but is it the competition that drove the boat?
I can't speak for Joe and he'll answer, but I think no, it's actually has nothing to do with competition. In fact, we never really ask what anybody else is doing. It's really the standard of what we should be offering our patients. It takes a little more time, but it's really important. And we like to think, let's raise the bar on reconstruction to the highest level we can get. I don't know what people are doing around town, to be honest with you. So yeah, I don't know, Joe, is it different for you?
I mean, I think that what has driven the nerve reconstruction in general has been the growth of our facial nerve program through our plastics, because the expertise becomes so essential for that, and the science is, or at least the surgical practice has become very advanced in that. And so when it comes down to doing the mental nerve or the lingual nerve or trying to repair something else, it's almost second nature at this point. But I think you're right. Like we're trying to do the best thing for the patient that we can. The interest is like the evolution in the techniques. Are you using cable grafts or Axogen, or like what is
Axogen all the way.
Yeah.
And then usually the connectors are genius, absolutely, because of the transparency. I think it makes it so much easier. And the science actually makes sense. I mean, it's really simple if you look at it. You're just allowing the body to heal itself, and you're aligning the cables properly. That's all you're doing.
Yeah. Yeah.
Yeah, we do the oxygen too, but I think in the benign disease, what we learned from you know, Dan Petrosar, and from probably picked it up from you guys. I mean, we just unroof, and you know, if it's necrotic bone, we just drill out the bone like we would do a mastoid to preserve the facial nerve. You know, I mean,
Yeah.
it's crazy, right? You know, what we're used to doing is cutting the nerve at either end and then going, here, I got the dead bone. I mean, could you imagine doing that in a mastoidectomy? You know, I drilled through the facial nerve in the front at the first genu and the third genu because it was easier to do. So just unroofing that nerve makes a huge difference. They get beat up, but it really makes a difference.
Yeah.
How often are you able to preserve the nerve in benign pathology? Like if you have a cyst and it's closed, or like where's your line that you make the decision on cut it and recon it versus try to preserve it?
So for benign tumors, I've gone away. Bob Marks was my mentor, who was very advocate of unroofing it and then decorticating it. But really, from a standpoint with the myeloblastomas, or any kind of myxomas, I cut it. I mean,
Yeah.
with the success rate around 86 with Axogen grafts, if you do it properly. And the thing is, it's an open field for us. So reality is it's really surgically easy versus trying to do an adogenic injury. So really from standpoint, I think a success rate, obviously if you mangle the nerve during unroofing it, you still need to do a graft it. So from right away, from a oncological safe margins principle, I would say I would do a 95% of all benign tumors. Cysts are a little different. I mean, there is no potential contaminating it. So I tend to laterally decorticate or move the nerve more. But for tumors, 95%, just cut them, resect them.
And to add a point, I mean, sometimes you're able to just pull through it. You don't have to decorticate. You can just cut the tumor, maybe at the distal end, cut the nerve, and then when you do your proximal and distal osteotomy, you just remove the segment, and you're able to just pull through that nerve, and then you can just do one coaptation if you need to have the primary nerve repair.
So James, you are not doing avascular nerve bone grafts anymore.
I have not taken a hip or any type of vascular bone since 2015.
So you're taking your stem cells from where, and how do you process them?
Anterior hip, and usually it's Terumo has, I've always used Terumo because that's what I learned in Miami, and it's centrifuge it. And the key, I think, is 240 cc's. I get the maximum, and that goes down to about 20 cc's of concentrated mesenchymal cells. And really from a standpoint, if you look, and I'm going to do a study, try to do a volumetrics with autogenous versus old school method of mandibular reconstruction with autogenous bone graft, there is an automatic 30% residual reabsorption about 6 to 7 months. The volume, I'm not seeing that with the mesenchymal cell or the tissue engineering technique. And I think it's twofold. It's the mesenchymal cell that's giving the signal. I don't know if it's the surface of the stem cells or the mesenchymal cells, because those die in a hypoxic environment. We know it's a complete hypoxic environment. No cells are going to be alive in the center core region. So you would think, but talking to some guys that research at Johns Hopkins, and they think it's really the concentration of those cells with the surface receptors. Even if they die, those receptors are still, the membranes are around. For some reason, the body wants to retain that bone. If you look at all my panorexes, we actually have to level out the bone. It will form into, the muscles will form it into a natural mandibular shape, but the volume of it does not, unless I have an infection, and then it goes away, obviously. But if we're able to keep that soft tissue intact and the bone forms in about 8 months is probably the earliest I'll go in now, to about a year, that bone does not receive, even with dental implants, it does not reabsorb.